So the session today is going to be around the diagnosis and the clinical management of thalassemias. And yeah, as Halima pointed out earlier, the kind of red cell service here does tend to be focused more around sickle cell disease. We have a few patients with thalassemia, relatively small number, but I think it'd be quite nice to have a bit more in-depth discussion about thalassemias. So if we start off just by having a definition of what is thalassemia. So this is a definition taken from Barbara Bain's book on hemoglobinopathy diagnosis. Thalassemia is a name given to a globin disorder that results in a diminished rate of synthesis or one or more of the globin chains, and consequently a reduced rate of synthesis of the hemoglobin or hemoglobins of which that chain constitutes a part. So basically it's a defect in globin chain synthesis, and we all know that. And the name of the thalassemia is taken from the globin chain, which is not being synthesized or not being synthesized in normal rates, at a reduced rate. So for instance, beta thalassemia refers to the situation with a beta thalassemia, where the beta globin chains are being synthesized at a reduced rate or not being synthesized, and vice versa for alpha. Thalassemia usually results from mutations or deletions of single or multiple globin genes or the promoter sequences of the globin genes. Okay, and just some kind of background information which I'm sure you're all familiar with. So as we all know, the structure of the hemoglobin molecule is that it is made up of 2 alpha and 2 beta globin chains, with a central iron, central heme molecule containing iron at the center of each of the globin chains. Yeah, and within the red cells, the heme component is synthesized both in the mitochondria and in the cytoplasm or the cytosol of the red cells, and the globin chains are synthesized separately in the cytosol, and then they come together later on after being synthesized. So synthesis of globin. So there are various types of globin chains, which we're going to talk about as we go along, which combine, as I mentioned earlier, with the heme to form the different hemoglobin molecules. And the globin chains are arranged in 2 clusters, what we call the beta cluster, which is located on chromosome 11 on the short arm, and the alpha cluster, which is located on the short arm of chromosome 16. And here you can see that in a kind of diagrammatic representation. So here we have the alpha cluster, which is made up of some chains which are expressed in utero. So the zeta chains, which make up some of the embryonic hemoglobins, and then the alpha globin genes, which result in synthesis of alpha-2 and alpha-1 globin chains. And then on the beta cluster, we have again some of the kind of embryonic chains, and then the gamma globin chains, and then the delta and beta globin chains, which genes leading to the delta and beta globin chains, which make up the predominant hemoglobins that we see during adult life. And this is a kind of representation of the change in the different globin chain synthesis during kind of gestation. And you can see here the alpha chains start to be produced very early on during gestation, kind of in the first few weeks really of gestation. The alpha chains start to be produced prior to, along with some of the zeta chains, which are also on the alpha cluster. The beta chains, gamma chains are produced predominantly during the gestation period in utero and up to about 6 months post-delivery, and then the production of beta globin chains begins and takes over from the gamma globin chains. So hemoglobin F is replaced by hemoglobin A as that happens. Now, I think the very interesting thing about this is the implications on survival of the babies and adults with different types of thalassemia. So with alpha thalassemia, we can see here that if the developing embryo is unable to produce any alpha chains at all due to homozygous alpha-0 thalassemia, so they have no functioning alpha globin genes, then you can see that from very early on during the in utero period, the baby would not be able to synthesize any hemoglobin, and therefore this is almost universally lethal in utero. Alpha thalassemia major is not compatible with life beyond a few weeks of gestation. There are a few exceptions where this has been picked up very early on, and in utero transfusions have allowed the babies to survive. But we're really talking about a handful of exceptions. Generally, alpha thalassemia major is not compatible with life. On the other hand, with the beta thalassemias, the picture is quite different, because as you can see, the gamma globin chain production persists past the postpartum period, into a few months postpartum. So beta thalassemia major manifests a few months after birth, where there is obviously an opportunity to diagnose a condition and to intervene with the commencing transfusions. So here's a recap of the different hemoglobins present in adults under normal circumstances. Obviously, the predominant hemoglobin is hemoglobin A, composed of 2 alpha and 2 beta globin chains. And then there's a small amount of hemoglobin A2 composed of alpha and delta globin, and a small amount of hemoglobin F persists into adulthood, but it typically makes up less than 1% of hemoglobin in adulthood. And here is an HPLC plot showing the normal hemoglobins expected in adults. So the major peak here corresponds to hemoglobin A. This peak here corresponds to hemoglobin A2, and here hemoglobin F, or fetal hemoglobin, here. Okay, and these other peaks here are likely to represent glycosylated hemoglobin, hemoglobin A. So the thalassemias, just coming back to kind of the more kind of epidemiological and clinical kind of aspects of thalassemias. So the genetic disorders, which, as we mentioned, are characterized by defects of globin chain synthesis, and worldwide they are the most common inherited single gene disorders. Okay, and in terms of the distribution, like many of the other hemoglobin disorders, such as sickle cell disease and some of the other red cell disorders like G6PD deficiency, the distribution overlaps and correlates very closely with areas of the world which have malaria prevalence. And here you can see that quite nicely in areas of West and Sub-Saharan Africa and the kind of Asian and subcontinent and the Far East as well. So how do we classify thalassemia? Well, we generally tend to classify it according to the globin chain affected, which I've already alluded to, and also according to the clinical severity. So previously we used to talk about kind of thalassemia major, thalassemia intermediate, and thalassemia trait or thalassemia minor. We tend now more to talk about transfusion dependent and non-transfusion dependent thalassemias. And here's just a quick recap again about the globin chain, the globin gene clusters, which I've already spoken about earlier. So if we talk first about beta thalassemia and then about alpha thalassemia. So beta thalassemia is due to a deletion or a mutation in the beta globin genes, as we've already seen on chromosome 11, which results in the reduced or absent production of the beta globin chains. And the prevalence is mainly in the areas which I've shown previously on the map, but with reference to beta thalassemia in particular, the Mediterranean countries, Africa, and Southeast Asia. And obviously the name thalassemia comes from the Greek. Thalassos in Greek means sea, and emia refers to the blood. So it's really kind of a blood disorder related closely to the sea, and the sea here refers to the Mediterranean Sea. So the incidence of thalassemia, so here we can see kind of like a inheritance pattern of beta thalassemia. So it's inherited in a kind of autosomal recessive manner. Here you can see the nomenclature is the normal beta globin gene is represented by just a standard beta, and the beta0 here represents a mutation or deletion whereby the gene leads to the gene has no output of beta globin protein. So here you can see the inheritance pattern. Again, here this is the individuals with heterozygous beta thalassemia or thalassemia trait, normal individuals, and here we can see that two individuals who have heterozygous beta thalassemia have a 1 in 4 chance of having an individual with thalassemia major or homozygous Beta0 thalassemia, and also a 1 in 4 or 25% chance of having a normal offspring. There are also mutations which result in reduced beta globin synthesis, but there is some output of beta globin from the gene, and that's designated as beta plus. Okay, so we talked about the carriers, we talked about normal individuals, and we talked about homozygous or individuals who are affected with thalassemia major. But we can also see here that there are individuals who have something in between, which we have called thalassemia intermedia. Okay, and that can result from an individual who has a beta0 and a beta plus mutation, or two beta plus mutations can also result in thalassemia intermedia. Okay, and this again is just showing the different combinations of genotypes and the kind of resulting hemoglobins which are present in those individuals, and the resulting correlating clinical phenotypes. So normal individuals here, this would be a carrier heterozygote for beta plus thalassemia. So these individuals will be asymptomatic or have a very mild anemia. Here is a heterozygote for beta0 thalassemia. These individuals often have mild anemia and microcytic hyperchromic red cell indices. This is an individual with thalassemia intermedia, which usually is a non-transfusion dependent state. And this individual is homozygous for the beta plus thalassemia mutation. And then we can see here another combination leading to beta thalassemia intermedia, the beta plus and the beta0 thalassemia inherited together. And here individuals with transfusion dependent thalassemia or thalassemia major who are homozygous for the beta0 thalassemia. And these individuals obviously require regular red cell transfusions in order to survive. So how do we diagnose beta thalassemia? So obviously the clinical picture is very important, but in terms of laboratory diagnosis, if we just kind of focus on that, so the full blood count, parameters, reticulocytes, blood film, and this is referring to alpha thalassemias, which we'll come on to later. And then HPLC, or hemoglobin, high performance liquid chromatography, hemoglobin electrophoresis. And then in cases where the diagnosis is not established or completely clear from the HPLC, then genetic diagnosis is important. Generally, that tends to be the case for most alpha thalassemias. So the main kind of diagnostic test for identifying individuals with beta thalassemias are the presence of raised hemoglobin A2 on HB electrophoresis or HPLC, in the absence of any other causes of raised HbA2, which we'll come to later. The normal kind of range for HbA2 is that it makes up between 2 and 3.5% of adult hemoglobins, and if it's above that range, then this is pathological, and in the absence of other causes of A2, diagnostic of beta thalassemia. Just some considerations which is important to bear in mind. So if beta thalassemia is co-inherited with delta thalassemia, that can kind of confuse the picture, because this will result, the presence of delta thalassemia and the reduced synthesis of the delta chains which make up part of hemoglobin A2 will mean that you have a lower A2 percentage. That can kind of make it more difficult to diagnose beta thalassemia due to the reduced levels of hemoglobin A2. Co-inheritance of alpha thalassemia with beta thalassemia can result in partial normalization of the red cell indices and the hemoglobin because it improves the globin chain imbalance. And in the case of HBH disease, when that's co-inherited with heterozygous beta thalassemia, the A2 percentage can be in the normal range. Okay. And with some delta chain mutations, that can result in a split hemoglobin A2, because you've got two different delta chain variants. So you have two separate HbA2 populations, and they can show up as two separate peaks on the HPLC. So if you're only reporting one of those peaks, then you may underestimate the HbA2 and then miss the diagnosis of beta thalassemia. So it's very important to make sure in that situation that you're reporting the total hemoglobin A2 percentage by accumulating the different HbA2 peaks. And other kind of indicators, laboratory indicators of beta thalassemia. So in some of those situations where we've talked about it may be difficult to kind of identify and diagnose beta thalassemia, there are other indicators which might be helpful. So raised HbF level, and it can vary, but often in the range of about 5% in patients with heterozygous beta thalassemia. Okay. I did mention that there are other causes of a raised hemoglobin A2s to bear in mind. It's important to be aware of those, and they're listed here. So congenital dyserythropoietic anemia, sickle cell trait, hyperthyroidism, megaloblastic anemia. Actually, megaloblastic anemia can cause either a high or a low A2, can cause either, and antiretroviral drugs used to treat HIV can also increase the hemoglobin A2. Iron deficiency can depress the hemoglobin A2. In the presence of other hemoglobin variants, the hemoglobin A2 level may be falsely elevated by degraded variant or glycosylated variant. So what you find is you find a peak on the HPLC plot, and then next to that peak, you find a much smaller peak, which is a degraded kind of element of the main hemoglobin, or a glycosylated element of the main hemoglobin. And that can sometimes overlap in the A2 window. So you may get a falsely elevated reading for hemoglobin A2. Okay, so moving on to the kind of clinical presentation and manifestations. So thalassemia major, in general, we're talking about beta thalassemia here. It usually presents with severe symptomatic anemia after the age of 4 months, which is roughly when the switch occurs from the gamma globin to the beta globin chain production. These patients or these individuals may have hepatosplenomegaly due to extramedullary hematopoiesis. The blood film would show gross hyperchromia, poikilocytosis, and usually numerous nucleated red blood cells. Bone marrow biopsy would show erythroid hyperplasia, and we've already mentioned the features of extramedullary hematopoiesis. Clinical features include chronic fatigue, failure to thrive, jaundice due to the increased hemolysis of the red blood cells, delay in growth and puberty, skeletal deformity, splenomegaly, and iron overload. Now, most of these features are in individuals who are identified late or not adequately transfused. So with kind of early institution of regular transfusions, we should be able to avoid many of these kind of clinical manifestations, particularly the skeletal manifestations. Other complications, so gallstone formation and biliary complications, cardiac failure due to both the anemia and due to iron overload, endocrinopathies, and liver failure. Okay, again, these mainly due to the iron overload. Okay, and this is kind of a picture that we used to see in the past of, and still present obviously in many parts of the world, where children are not adequately transfused and then do develop these skeletal abnormalities. And here you can see this expansion of the maxillary bones here, and also frontal expansion as well, although that's not so prominent here. Okay, so basically management of thalassemia major, you know, the main kind of features of the management include transfusion therapy, management of iron overload, splenectomy if the patient has a very high transfusion requirement, may be indicated and may be beneficial, supportive medical care, and then kind of endocrinology input. Hormone replacement therapy may be required, particularly growth hormone therapy in growing children. Hydroxycarbamide may be of benefit in certain individuals, particularly if they have certain genetic modifiers like the XMN1 polymorphism in the gamma globin gene, which responds to hydroxycarbamide treatment. And then a minority of patients will be put forward for and eligible for bone marrow transplantation and newer therapies, including gene therapy and newer drugs, which I will talk about later on.
Can I just ask, the hormone therapy?
Yeah.
Is that because of like iron deposition?
Yeah, mainly due to iron overload. So it's also important to bear in mind other clinical aspects when kind of dealing with patients with thalassemia. So they are more at risk from certain infections and sepsis, and many of these again are due to the iron overload. So even non-transfusion dependent patients are at risk of organisms which thrive on iron, so siderophilic organisms. The classical one is Yersinia, but also other gram-negative organisms. And those patients who are splenectomized obviously need to be immunized and on regular antibiotics to reduce the risk of pneumococcal and meningococcal sepsis. I think we've done that slide. So in terms of the transfusions, obviously because these patients are going to be on lifelong transfusions, we try to match and give them phenotyped red cells, and generally aim for pre-transfusion hemoglobin of about 95 grams per litre, in order to ensure patients are free from symptoms of anemia and to protect them from the extramedullary hematopoiesis as much as possible. Most patients will require transfusions somewhere between 2 and 4 weekly, so every 2 to 4 weeks. And mentioned already that if they have a particularly high transfusion requirement and splenomegaly, then splenectomy is a consideration. There are some other genotypes which clinically lead to thalassemia, either transfusion dependent or, in this case, more commonly non-transfusion dependent thalassemia. And this is co-inheritance of hemoglobin E with Beta0 thalassemia. And the reason why this gives rise to a thalassemia is because hemoglobin E itself is a thalassemic hemoglobin. So when hemoglobin E is produced, the RNA splicing only occurs about a third, between 1/3 and 2/3 of the time, and the rest of the time it's not correctly spliced. So that's why this is a thalassemic hemoglobin. And hemoglobin E is found commonly distributed in Southeast Asia. And as I mentioned, the clinical expression is variable, but most usually results in thalassemia intermedia. So moving on to the alpha thalassemias, I could pause there and ask if there are any questions before I move on. Anyone on the call? No? Okay. So with the alpha thalassemias, a lot of the clinical features are very similar, but the genetic diagnosis is a little bit, or the laboratory diagnosis is a little bit different, and in some ways a little bit more complicated, and we'll come to the reason for that. So alpha thalassemias are due to deletions or mutations in the alpha globin genes, and they result in reduced or absent production of alpha globin chains. Okay, and as we've mentioned and seen the reason for this earlier, it affects both the embryo and the fetus, as well as adults. Okay, and excess beta and gamma chains form tetramers. So beta tetramers are termed hemoglobin H, and gamma chain tetramers hemoglobin Barts. Okay, so you see both of these in patients with 3 alpha globin chain deletions. You see some elevated levels of hemoglobin H and hemoglobin Barts. And if you were to look at the hemoglobins in a fetus who had alpha thalassemia, homozygous alpha-0 thalassemia, you'd see mainly hemoglobin Barts. Yeah, and the severity depends on the number of alpha globin genes affected. So the reason why the diagnosis of alpha thalassemia is a little bit more complicated is because there are 4 alpha globin genes as opposed to the 2 beta globin genes. Okay, and there are various combinations of alpha gene deletions resulting in different genotypes and kind of clinical manifestations. So obviously this is a normal situation where you have a full complement of 4 alpha globin genes. And in this situation here, termed heterozygous alpha plus thalassemia, there is a deletion of 1 of the alpha genes. Okay, and these individuals are asymptomatic or may have an extremely mild anemia. Okay, in the situation here where they have a deletion of 2 alpha globin genes, 1 on each chromosome, so this is termed a trans deletion. So the deletion is across 2 chromosomes rather than on the same chromosome, or this could also be termed as homozygous alpha plus thalassemia. Okay? And again, these individuals are usually asymptomatic. They may have a mild anemia and mild hyperchromic microcytic red cell indices. Now, this is a situation where there are 2 alpha globin gene deletions on the same chromosome. This is termed cis because they're on the same chromosome, and this is the nomenclature for this is alpha-0 thalassemia. Okay, rather than alpha plus, homozygous alpha plus, this is alpha-0 thalassemia, where both the deletions occur on the same chromosome. Now, this does have genetic implications. Now, can anyone tell me why this has important genetic implications?
If the offspring gets the one with no alpha and the other partner also has another chromosome with no alpha on it, then it could be a...
So what will that result in?
So it'd be the hydrox one, so the kind of Barts incompatible gamma one.
Yeah. So there is a potential for this individual to have a partner who's alpha plus thalassemia, in which case the offspring would have a risk of HBH disease, 3 alpha deletions. But as Kat said, there's also potential for this this individual to have a partner who's also got alpha-0 thalassemia trait, and then the offspring will have a risk of thalassemia, alpha thalassemia major, or hydrops, Bart's hydrops. And this particular genotype is common in Southeast Asia and in the Mediterranean countries. And then HBH disease is where there is a 3 alpha globin gene deletions, so a single alpha gene on one chromosome and none on the other. And this has a variable phenotype between transfusion dependent and non-transfusion dependent thalassemia. And then, as we mentioned already, the Bart's hydrops, where there are no alpha globin genes at all, is incompatible with life.
Can I just ask a question? Why are the third and the fourth one, why are they different when they have the same number of alphas? So that alpha, like the cis and the trans, why are they, apart from obviously the inheritance, but
yeah,
clinically, are they different?
So we'll talk about that as well.
Cool.
Okay, so this is another kind of just a representation of the same thing that we've been talking about, so I'm not going to spend too much time talking about this. Okay, and these are some of the common deletions. Okay, so you can see now, in answer to Kat's question, I think we can probably answer that now. So we've mentioned already that there are 2 alpha globin genes on each chromosome. There's an alpha 1 and an alpha 2 globin gene. Okay, and most of the output, about 70% of the alpha globin output, is from the alpha 2 gene, and about 30% from the alpha 1 gene. Now, when most of the deletions span the alpha 2 globin gene, okay, most of these deletions, so these are the 2 most common ones, the alpha 3.7 and the alpha 4.2, and they normally affect the alpha 2. But when you have a deletion in the alpha 2 gene, there's an upregulation of the alpha 1 gene, so you get increased output of alpha chains from the alpha 1. So there's a compensatory upregulation from the alpha 1 gene. So that's why these individuals tend to have a kind of milder phenotype than these individuals, because they have an upregulation of the alpha 1 output. Okay, and then here you can see that the deletions causing alpha-0 thal span across both the alpha 1 and the alpha 2 gene, and also indeed all the other, most of the other genes in the alpha cluster as well. Yep. So yeah, kind of talked about that already. So yes, just focusing again a little bit more on the alpha-0 thalassemia, because it does have important genetic implications, as we've mentioned. So distinguishing between alpha plus and alpha-0 thalassemia, there are some kind of helpful parameters that help us distinguish. So the MCH tends to be lower in alpha-0 thalassemia. So if it's less than 25 picograms, the MCV also tends to be lower, and the RBC tends to be higher. So all of these features, which are seen in both alpha plus and alpha-0 thalassemia, but they tend to be more severe in the alpha-0 thalassemia, the indices, so that normally we take the MCH less than 25 as being an indicator of possible alpha-0 thalassemia. And the kind of geographic distribution of the alpha-0 thalassemia, we've already mentioned Southeast Asia and the Mediterranean countries. And alpha-0 thalassemia heterozygous, in the heterozygous state, results in a mild anemia. You may see hemoglobin H inclusions on the film, on the blood film, which are made up of beta globin tetramers. Okay. This is a blood film of a patient with hemoglobin H disease. So 3 globin gene deletions. You can just see here that the film is very abnormal with severe anisopoikilocytosis, and a lot of other features which are not very clearly obvious on this film, but cells tend to be poorly hemoglobinized with hemoglobin retraction. You may see basophilic stippling, although basophilic stippling tends to be more common in the beta thalassemia disorders. You can see here that there are a few target cells as well. And this is a hemoglobin H prep, so a supravital stain for the gamma tetramers, and you can see here that these cells, which are often described as golf balls for obvious reasons, are cells which contain the gamma tetramers or hemoglobin baths. Okay, and these cells here, which stain a lot more coarsely, are reticulocytes. Okay, but these are the cells that we're interested in. You see small numbers of these cells in alpha-0 thalassemia, heterozygous alpha-0 thalassemia, but this kind of number of cells is suggestive of hemoglobin H disease. And this is an HPLC plot in HBH disease. So here you can see the hemoglobin the hemoglobin A peak, but you can also see these two peaks here. Can anyone tell me what these are?
Fast-moving bands of the HPA.
Yeah, so they're the fast-moving bands, and they are formed of HBH, so hemoglobin H, beta tetramers. The reason why there are two peaks is this is in an adult. Okay, if it was in a so it's mainly beta tetramers. The reason why there are two peaks is not known definitively, but it's postulated that perhaps there are some dimers and some tetramers, which is why there are two peaks of the beta globin chains. Okay, so bringing it all together really from a laboratory diagnostic point of view. So when we're evaluating patients with thalassemic conditions in terms of the diagnostic aspects, what are we looking at? So obviously we're looking at the full blood count indices, so the hyperchromic microcytic indices, the raised RBC count. The RDW doesn't tend to be so high in thalassemias. Okay, if a high RDW is seen commonly in iron deficiency, but not so much in thalassemia. There's more of a uniformity in the hyperchromia and microcytosis in thalassemic conditions. And hemoglobinopathy results, so we're looking at the presence of the different hemoglobin species, hemoglobin A2 particularly in the diagnosis of beta thalassemia disorders. Blood film morphology to distinguish and differentiate between the carrier states or the heterozygous states and the more severe thalassemias, the thalassemia intermedias or the thalassemia major conditions. And then obviously transfusion history is an important aspect of determining whether patients have severe thalassemias and what are their transfusion requirements. The geography and the ethnicity is important in an assessment of individuals with thalassemia. And also what is extremely important is whether these individuals that we're seeing, whether they have childbearing capacity and whether we're seeing them in the antenatal situation or not, because that's obviously going to have very important implications for genetic, can have very important genetic implications and implications on what testing, what prenatal testing we offer. And partner testing obviously should be offered as well. Okay, so I've spent quite a long time talking about the kind of genetic aspects. There are also some important situations where patients with what looks like a beta thalassemia, a heterozygous beta thalassemia, have a more severe clinical picture and a more severe kind of laboratory picture, so more severe anemia than you'd expect and more severe red cell changes. Does anyone know what kind of things can kind of interact with the beta thalassemia to make it more severe?
Sickle trait.
So sickle trait is separate, because if you've got sickle trait, if you inherit that with beta thalassemia, then you're talking about sickling disorders. I haven't really talked about those today at all, but yes, obviously there is that interaction. But we're still really talking about the thalassemia. So what can kind of make what looks like a heterozygous beta thalassemia more severe clinically? So if you attended any of, sorry?
E-beta thalassemia, if there is a co-inheritance of hemoglobin.
Okay, that's good, Xavier. Thank you. Yeah, we talked about that. Yes, so that's definitely one. So there are some dominant beta thalassemia mutations. Okay, that's one possibility. And remember, in thalassemia, the key to a lot of the pathophysiological effects is the globin chain imbalance. Okay, so you've got a reduction in beta globin chain production with beta thalassemia. So if you've then also got a defect which causes an extra alpha globin production, so it is possible to inherit an extra alpha globin gene. So then you're increasing the chain imbalance further by pushing up the alpha globin chains, and you've got reduced beta globin chains, so that can cause a more severe anemia. So we do sometimes talk about testing patients for triplicated alpha or increased alpha copy number. So that's what we're talking about there. If it looks like a more severe thalassemia than you'd expect.
When more severe, you mean a more severe beta thalassemia?
Sorry,
Do you mean a more severe beta thalassemia or?
Yeah, more severe beta thalassemia in that case, yeah. And another point as well, which I didn't really touch upon, is that obviously in terms of the diagnosis of beta thalassemias, we rely heavily on the electrophoresis, but with the alpha thalassemias, the electrophoresis is unlikely to be able to kind of help us diagnose most of the alpha thalassemia. That's why on the HPLC reports, you'll see a lot of the time alpha thalassemia not excluded. You'll see that a lot. That's because there's no clear kind of hemoglobin variant or diagnostic feature on the HPLC. So we would normally have to resort to genetic testing if we wanted to look for a clinically significant alpha thalassemia disorder. Okay, so in the last few minutes, I'm just going to talk about some of the kind of more clinical aspects, and particularly focus on kind of iron overload and management of iron overload in these patients, because that's one of the really important key aspects of how well these patients do long term and the kind of the survival. So obviously we're very good at starting patients on transfusions because they're going to die very quickly if we don't start them on transfusions. But iron chelation is the next most important thing that we need to get right in these patients in order to prevent a lot of kind of long-term problems later down the line. Okay, so generally after the patient has had between 10 and 12 transfusions, or when the serum ferritin is more than 1,000, is when we start looking for and managing iron overload. Okay, and most of the iron chelating drugs, well, we only have 3 iron chelating drugs, but pretty much all of the iron chelating drugs can have an effect on the eyes and the ears. So it can cause sensory neural hearing problems and retinal problems, particularly with colour vision problems. So it's always best to do baseline kind of audiology and ophthalmology screening prior to starting any iron chelation. So this mainly refers to desferrioxamine and deferricyrox XJ, not so much with deferriprone. So management of iron overload. So serum ferritin of more than 2,500 is associated with significantly increased complications. As we're all aware, ferritin is an acute phase protein, so a single elevated result shouldn't necessarily be the guide for whether we base our decisions on iron chelation. It's kind of the trend and a consistently elevated ferritin. We normally would check the ferritin every 3 months in a patient who's on regular transfusions, and in non-transfusion dependent thalassemia patients annually. And in obviously the gold standard, and in the past, the way we would make a decision on iron chelation would be by measuring tissue iron overload on a liver biopsy. However, now thankfully we have non-invasive, very good non-invasive modalities for looking at iron overload. so the T2 star cardiac MRI and the hepatic MRI. With regards to the T2 star cardiac MRI, a value of less than 20 milliseconds is indicative of iron overload, cardiac iron overload. The hepatic MRI, whilst it is used in many centres, is affected by kind of acute phase elevations in serum ferritin. It also affects the kind of hepatic MRI results, and hepatic steatosis also affects the T2 star MRI results, hepatic MRI results. So much more accurate and much preferable is the R2 MRIs for the hepatic iron quantification, or the ferry scans, which we have access to. Yep, so that's what I just mentioned, referred to the ferry scan. Again, this is a non-invasive quantification of the liver iron concentration, and it's not affected by inflammation or cirrhosis, which I was kind of alluding to earlier. Okay, and when you see a ferry scan report, you'll see that they normally include a little table which tells you what the different values mean and what are the risks of complications with the different ranges of hepatic iron deposition. Below 3 is normally taken as normal, and a value of more than 15 milligrams per gram is associated with cardiac disease and a adverse outcome. And here is a kind of a picture of, you know, the R2 MRI images that are generated, and this is a contrast between a patient here who's got sickle cell disease and a patient here on the right who's got thalassemia major. And the striking thing is here that in sickle cell disease there's much less tendency for cardiac iron deposition and cardiac iron overload, which is why this area is white or not very dark, whereas there is a much higher tendency for hepatic iron deposition, whereas in thalassemias it's the other way around. There's a higher tendency for cardiac iron deposition, which is this darker area here, and less so in the liver. And even to this day, it's not really very well understood why that is the case. Okay, and then here's just some kind of data on, you know, the importance of iron chelation. So here we can see by the different decades the improvement in survival of patients with thalassemia, and obviously, as I'm sure you would have guessed, this correlates with the development and clinical use of the different iron chelators. Okay. So here you can see in the 1960s, before there were any iron chelators available, that by the age of 30, the survival probability was only 25%, whereas now with good iron chelation, you can see that there's been a significant improvement. And not only does it correlate with patients being able and offered to have iron chelation, but their compliance with iron chelation. So here we can see that patients who are good compliers and have the prescribed number of infusions, we're talking here about desrioxamine, do very well, and those who are very poor compliers do much worse. And here we can see the cardiac disease-free survival and how it correlates with cardiac disease. How it correlates with the serum ferritin. So this is patients whose ferritin is above 2,500 less than 33% of the time, as opposed to patients who have high serum ferritin measurements for more of their tests have high serum ferritin measurements, and you can see the difference in cardiac disease in correlation with those. Okay. Obviously, iron chelation is not without its kind of problems, and just looking at this chart and the different impacts iron chelation therapy has on patients, makes it obviously easy to understand why patients may not be very compliant, particularly young patients who are kind of going to school, teenagers, who have other priorities in their life, young adults who are working. You can understand why iron chelation may not be their immediate priority at that stage in their life. And you can see all the kind of, effects associated with iron chelation. So there are 3 different iron chelators which are available to us. This is not really in the right order, but desferrioxamine was the first one to be developed in the 1960s, and it has to be given subcutaneously or intravenously. The next one to be developed was deferiprone, which is given orally 3 times a day. And deferiprone tends to be better in terms of reducing cardiac iron overload than the other iron chelators. And I've just listed here some of the important side effects for the iron chelators. So deferiprone in particular is associated with idiosyncratic risk of severe agranulocytosis. And there's no way of predicting this. So that's why patients who are on deferiprone are recommended to have weekly blood tests for the whole duration of the treatment. So as you can imagine, that's a fairly big commitment from the patients to have to come for weekly blood tests when they're taking this treatment. Deferricyrox, most common side effects, GI side effects, and it can cause hepatic and renal impairment. Desferrioxamine, you can see there. Okay, and combination therapy can also be used in patients with severe iron overload. The advantages of combination therapy are that if you're using 2 drugs instead of 1, you can reduce the doses of each of the 2 drugs and therefore reduce the side effects of each of the individual drugs. And here, just to show you the difference in of the differential effects on cardiac iron overload of deferiprone compared to desferrioxamine. So you can see here the T2 star improves considerably more with patients who are taking deferiprone as opposed to desferrioxamine, and the improvement in ejection fraction is also greater in patients on deferiprone.
Do you find that you have many patients that you've got on combined therapy?
No, relatively few. And then just to finish off really, in the last 2-3 minutes, I'm just going to talk to you about some of the other therapies that we have available now for patients with thalassemia. So this is a drug called mitapivat, which some of you may have heard of. At the time that this trial was running, we had some patients enrolled in this trial. So this is a trial in patients with non-transfusion dependent thalassemia of this agent called mitapivat. Now, interestingly, this molecule, does anyone know what this molecule does and what it was initially developed for? So it's actually a PK activator, so pyruvate kinase activator, and the disease that it was obviously initially developed for was PK deficiency, so patients with pyruvate kinase deficiency. So the same company, Agios, who developed this drug, initially did trials in patients with PK deficiency, and what they saw was that obviously the mechanism in PK deficiency is easier to kind of grasp and understand, but they postulated that this drug could have beneficial effects in other red cell disorders because basically it drives the glycolytic pathway, and because if you remember where pyruvate kinase is, or pyruvate is, sorry, it's right at the end of the glycolysis pathway. So it drives the glycolysis pathway and increases ATP generation. So basically increases the energy generation in the red blood cells, and it prolongs red cell survival. So on the basis of that, they started doing trials in patients with initially non-transfusion dependent thalassemia. And although this trial is now closed, there are some new trials now which we're currently recruiting for in patients with both non-transfusion dependent and transfusion dependent thalassemia. They're called the Energize and the Energize-T trials. Okay, so we're currently recruiting to patients in both of those trials. And also there are some trials now of also this drug in sickle cell patients as well. So really, it's kind of being used in all types of red cell disorders to try and prolong red cell survival and health of the red cells. Yeah, and here you can see the kind of the description of the trial. No, that's a different trial. Apologies. Okay, and then we now also have bone marrow transplant has been an option for quite some time in patients with beta thalassemia, outcomes being considerably better when it's done in younger individuals, so in children. And as you may know, at St. Mary's, there is quite a big program for transplanting children with beta thalassemia. In adults, because of the onset of complications of iron overload and other complications, the outcomes tend to be much worse in adults, so much better to do it earlier on in childhood. But obviously, transplantation depends on having a suitable donor, and gene therapy, which is now another option, doesn't rely on having a suitable donor. So there are two methods of gene therapy. Both involve collecting autologous cells from the patient and either introducing the beta-globin gene using a lentiviral vector and then replacing those cells giving those cells back to the patient after conditioning, or another method which is using CRISPR-Cas9 technology to knock down this gene called BCL11A. So BCL11A is an important gene that regulates the switch from gamma to beta globin chain synthesis when that switch occurs after a few months of life. So knocking down this gene reverts to gamma globin chain synthesis and production of fetal hemoglobin. So knocking down this gene can result in very high levels of fetal hemoglobin, which are enough to protect the individual from the effects of thalassemia and allow them to have a good hemoglobin level. So both of these methods have been successful in trials, and trials are still ongoing using both of these methods in patients with thalassemia with very good kind of outcomes and results.
And in those gene therapies, presumably you take patients' hemopoietic stem cells that are being treated with that CRISPR.
Yeah.
And is it then like an autologous transplant, essentially?
Yeah.
With those new gene edited?
Yes, you take the stem cells and send them off to a lab where they do the, either the transfection or the CRISPR-Cas9 manipulation. And then in the meantime, yes, you condition the patient as you would for an autologous transplant.
But as opposed to, so for example, in the hemophilia gene therapies, I think they have you can have a sort of relatively small amount of cells that might not even settle in the marrow, but in the liver or elsewhere, that then produce a bit of factor.
Yep.
That obviously doesn't, so this is not the same. This is like essentially replacing, I mean, in crude terms, the whole bone marrow essentially with a new cell line.
It's a similar principle. I mean, with the haemophilias, obviously you only need a small amount of factor production to kind of ameliorate the phenotype. But with these conditions as well, you certainly don't need 100% chimerism. Like with a malignant disease, you want to completely, obviously get rid of the malignant clone. So you have to, you're trying to achieve the 100% or as near to that, chimerism. With this, you don't need to. I mean, even if you have 50% donor chimerism, that would be able to sustain enough hematopoiesis to kind of, protect the individual from the kind of effects, long-term effects of anemia and thalassemia.
And is that the same gene therapy or like CRISPR techniques that they're using for sickle cell as well?
Yes, same technology being used for sickle cell as well. Yeah. Both of the technologies, the lentiviral and the CRISPR-Cas technology.
Do you think that X amount of years' time, this is what everyone will have? Anyone who's born with significant thalassemia?
Well, in these countries, yes. I mean, obviously we have those options, but you've got to remember the global, reach of these technologies is, very far from reaching, a lot of the countries where these diseases are so prevalent. So I think looking on a global scale, the impact is going to be fairly small. But looking in high-income countries, yes, we should be able to offer it to to a lot more patients as time goes on. Any questions or comments from anyone on the call, on the Teams call?
Do we have any patients that have gone through that gene therapy?
For the gene therapy? No. But the lead for the trial in the UK is Josu, Prof. de la Fuente, who works at St Mary's Hospital. And
he had some adolescent patients, didn't
he? Yeah, he has some adolescents,
here.
yeah, but I don't think that we referred him any patients. So he was basically recruiting patients with Beta0 Thalassemia, homozygous, and also the Beta0 Thalassemia.
Thank you very much. Need to go through the please.
No, I think we're done anyway. I think
I
so.
missed it at the beginning, but how big is our thalassemia population here?
Yeah, we have very few. So in terms of thalassemia major, I mean, Halima might know the numbers better than me, but we probably have, I would say, 5 or 6 thalassemia majors only, and thalassemia intermediates considerably more. But probably we're talking about kind of 30 or so, not much more than that. Whereas obviously sickle cell, we've got a population of about 450, 500 patients. So most of the thalassemia in the UK is concentrated around kind of North London. So UCH and the Whittington have a large population, mainly Turkish and Cypriot community in that part of London, and then also amongst.
London has quite a lot.
Well, and then the kind of the Indian subcontinent populations, as you say, in East London, and then in the kind of Midlands and kind of northwest of the country, you know, the Lancashire and those kind of areas where there's a big population of kind of you know, the Indian subcontinent kind of populations. So yeah, that's where most of the thalassemia is focused in the UK. So we have in West London relatively small numbers. Yeah.
So it's a routine part of an antenatal screening, isn't it?
Yes, I mean so hemoglobin electrophoresis is routine part of antenatal screening. So we're going to pick up the beta thalassemia in that, not necessarily the alpha. So we still may need to, you know, make clinical decisions about whether, you know, genetic DNA testing is required in those individuals.
Thank you, that was really helpful.
Yep, brilliant.
Thanks, Asad.
Okay.